Hey, DNA. Kate Wilson here with another episode of All Access DNA. Why are men and individuals with prostates less likely to see a genetic counselor? Why might people assigned male at birth see a genetic counselor? Today, we talk to Brittany Szymaniak, who is both a PhD and certified genetic counselor. Brittany works in the urology department at Northwestern Medicine as part of the Cancer Genetics Program, where she focuses on prostate GU genetics as well as male infertility. Let's get started. Hi, Brittany, and welcome to All Access DNA.
Hey, thank you for having me. I'm excited to be here.
Well, we're fortunate to have you on today and kind of doing a bit of a grab bag of a few different questions and queries, I would say, related to healthcare in men. So we'll talk a little bit some about hereditary cancer, but also reproductive health. I'm thinking the best place, why don't we start with inherited cancers, just because we are coming out of Prostate Cancer Awareness Month. And so that way we can talk a little bit more about cancers that are associated with people with prostates. What cancers are most linked to inherited genetic mutations in people that are assigned male at birth? So what cancers do we need to be concerned about having a hereditary component?
Yeah, so I think if we start like really kind of 30,000 foot view level, only about 5 to 10% of all cancer is going to be due to some type of inherited component. So then if we narrow it down and kind of look at more organ specific cancer risks that may be associated with that, if we think about prostate cancer specifically, if we have somebody that has more localized, low risk or low grade prostate cancer, that probably is going to be closer to that 5 to 10% risk category. If we have somebody that has more aggressive prostate cancer or metastatic disease, this is where we get into potentially like a 12 to maybe 15% risk, depending on what data you look at. So if we think kind of specifically for somebody who's assigned male at birth, prostate cancer, of course, is going to be the one organ kind of specific risk that we think about. But certainly there can be inherited risks for other types of cancers that would affect these individuals as well.
So prostate cancer, most time probably not hereditary, but there are some cases that may be cause for concern or at least looking into it a bit more.
Exactly.
And one of the, I would say the most common ones we hear about is BRCA or BRCA genes, right? And so I think we've seen a few different folks. I know Angelina Jolie, I think Olivia Munn, maybe more recently, had talked about having BRCA or BRCA mutations and their concern for breast and ovarian cancer. Does BRCA mutations impact men as well as women? And if so, how does it affect those that are assigned male at birth?
Yeah, that's a great question. So I think we in the genetic space have historically studied BRCA1 and 2 in the context of breast and ovarian cancer. So that's really kind of where the focus has been. And I feel like when you have individuals that are diagnosed with breast cancer, often one of the things that they think about, maybe in the top 5, is could this be due to a genetic cause? Could this be related to BRCA1 or 2? And I think in the prostate cancer space, we have kind of been behind in that. So these are 2 of the genes that have been very strongly associated with inherited prostate cancer, but it really wasn't something that we were testing specifically for the indication of prostate cancer until maybe 2017, 2018, versus in the context of breast and ovarian cancer, it was like early 2000s. So we are definitely very behind in that regard about like thinking about prostate cancer as being an possible inherited cancer. And so BRCA1 and 2 is always going to be at the top of my list of things that I think about. And so if we look at these families, of course, there are going to be risks for individuals assigned male at birth, but also female at birth. So this is something that can impact pretty much everybody in a family.
So let's say, somebody who is a female but has a significant family history of prostate cancer. Is that something where they should be looking to find somebody like yourself or talk to a genetic counselor about that family history?
Yeah, absolutely. This is something that I always encourage my patients to think about and also providers to think about, is that we're not just asking about cancer histories that may be relevant for that individual, in the sense that like I have breast and ovary, so I'm only going to be thinking about, family history of breast cancer and ovarian cancer. But the fact that for many of these genes, there's going to be a whole spectrum of cancers that we can see associated with them, it may be the situation that maybe there's not enough women in the family to show something
Right.
like breast and ovarian cancer. So we're not seeing those patterns, but maybe we're seeing the prostate cancer as one of the main patterns. So I think it's really important to kind of holistically look at the family and what are the different cancers that we're seeing and what are the different genes that could be connected back to them that could be relevant for, a wide variety of cancers.
So then I would say the flip side, then you could have somebody who's male assigned at birth and he has a family history of breast and ovarian cancer, but that may mean that they need to look into it a bit more because they themselves may be risk at prostate cancer if there's like an underlying BRCA mutation.
Exactly. And I feel like I've run into this situation since I started practicing that I'll have patients that come in and they're like, oh, well, like I'm only worried about the prostate cancer history in the family, but I'm not really thinking about the breast and ovarian cancer because that's not related to me. And it's like, well, from a genetic standpoint, this is actually something that we think about. But I think from a patient perspective, this may not be something that, especially for men, that we're inherently connecting the dots between. And especially if you have somebody that's meeting with a urologist, maybe they only are in the habit or workflow of asking about family histories of prostate cancer or other GU specific cancers, so like kidney cancer or bladder cancer. And they're maybe not asking about things like breast, ovarian, or pancreatic cancer, for example. So I think this is kind of like on the patient education side, thinking about kind of more of the different cancers in the family, but also on the provider side and thinking about other cancers that could impact a patient.
True. Very good point. If somebody does have concerns, so we're thinking BRCA, but there might be other genes potentially that you're thinking about as well. Is there testing that's recommended or something that can be done?
So I think in the cancer genetic space as a whole, we have certainly struggled with the criteria that we develop in terms of who actually qualifies for genetic testing. I think for any patient that has a cancer diagnosis, it's always appropriate for them to think about whether or not genetic testing could be helpful for them. We have specific criteria about who qualifies for testing when it comes to the aggressiveness of somebody's prostate cancer or their prostate cancer in combination with other family histories. So this is where it sometimes can be helpful to meet with a genetic counselor to kind of go through that history in a little bit more detail. But I think for any patient that has prostate cancer diagnosis or a cancer diagnosis in general, this is something that's worthwhile for them to think of.
One cancer that would come up a lot back when I was practicing clinically, and at the time, because it's been a while, we didn't necessarily have a lot of information to give, is testicular cancer. So what do you tell patients that ask about causes or the genetic testing for testicular cancer?
Yeah. So this is, I feel like if we say that we are struggling in the prostate space, a research and a genetic testing level, I feel like we're probably even further behind on the testicular cancer side. There's a couple genes that often have been associated back with very specific types of testicular cancer. So usually we think about things like STK11 that can be associated with a condition called Peutz-Jeghers syndrome, that there's a very specific type of germ cell testicular cancer that we can see. Peutz-Jeghers is very rare. So this usually is not, family history-wise, something that we commonly would see. But CHEK2, there's a lot of discussion about whether or not this is something that can be connected back to testicular cancer. But it's tricky when we have families, because we certainly do see it, where there's family histories of testicular cancer for multiple individuals, but we don't always have clear testing that we can give patients. So I feel, and even from like a familial risk perspective, that's also not really clear. So I think there's still a lot of research and a lot of investigation to be done in that space, even more so than what we're thinking about on the prostate cancer side.
And how does somebody find someone like yourself or get to a clinic where this might be an option? Because I know, again, in GU settings, it may not always be commonplace to have genetic counselor or to be even offered genetic testing.
Yeah, so I think I'm in a little bit of a unique situation being in urology, but I would say for most of my colleagues, they're going to see a wide variety of indications. Even myself, I see it outside of GU. I think this is a really important discussion for patients to start with, like even a primary care, in talking about the family history and bringing this up, especially because I have some patients that maybe don't have a lot of information about the family history. So I think sometimes there's something to be said for discussing genetic testing, even in the context of not knowing a lot about the family. Because as genetic counselors, of course, we have a very high degree of regard for the family history, but I think it's not the be all end all when it comes to genetic testing. So I think discussing with a primary care, discussing with oncology, Or if somebody is particularly motivated, it's not like we always need to have a referral to meet with somebody in genetics. So I think it's helpful to discuss with a provider about this information because maybe they can get you connected with a genetic counselor that's within your system. But through the NSGC website, we do have a way for individuals to go there and find a genetic counselor in their area. So even if it's not somebody that they're being connected within their hospital system, there could be somebody else in the area that they could meet with.
And we'll put a link in the show notes to some of that information too to help folks find a genetic counselor in their area. And you mentioned being in the urology setting. So urology, there may be a variety of indications or reasons why you might meet with a patient. So some are related to prostate cancer or family history of cancer, but also you get quite a few probably, I'm imagining, on the reproductive side of things. So I was wondering if you could tell us a bit more about the genetics of male reproductive health and fertility. And so why would you see somebody in that space?
Yeah. So often the way that these patients are getting to me is that they and their partner have been trying to get pregnant for a certain amount of time. Usually the male partner ends up meeting with somebody in andrology, which is within the urology department, for an evaluation for infertility. So they could be meeting with this andrologist. They're typically getting like hormone testing done. They often are doing semen analysis, taking kind of a more comprehensive medical history to kind of figure out if there are contributing factors to this. And often they will then get sent over to me on the genetic side because there is either low or absent sperm count for that individual, or there's some type of combination with abnormality in terms of hormone levels, or there was something unusual found on physical examination. So there's a couple different components that often go into this, but really fundamentally, it's usually if a couple has been trying to have children and trying to get pregnant and haven't been successful in that.
Okay. And what types of things, I guess, would happen at your piece of the visit, right? Because some of it's family history, but there may be some other things that are asked as well, or questions that come up.
Yeah. So there are pretty, I would say, kind of standard tests, genetic tests that we think about to help address infertility. So one thing that we often are doing is kind of a big picture chromosome analysis, something that we call a hereditary. So we're looking for rearrangements of the genetic information. So it's all there. It's maybe just not in the same order. Or we're looking for additional sex chromosome information. So we can sometimes have individuals that have an extra X chromosome instead of just one X and one Y. And this can throw off hormonal balances. This can lead to certain types of infertility that we may see with that. And then there's also genetic testing that we do specifically on the Y chromosome to help figure out if there's any deletions that have happened on there. So all of these chromosome-specific tests that we do is a way for us to assess whether or not any of these are possibly contributing or leading to that lower absent sperm count or abnormal hormone changes for a patient. And from a very technical perspective, when the andrologist does a physical evaluation, what they're also looking for is, of course, testicular size, but also if there's any changes to the structures associated with the testes. So specifically something that we call the vas deferens. So if there's anything structurally abnormal about that vas deferens or it's absent, this could indicate that there's one particular spectrum condition, cystic fibrosis or CFTR related disorder. So often if there's anything found on physical evaluation, that's also something that I'm assessing a patient for. So it's very gene syndrome specific outside of these kind of bigger chromosome genetic changes that we're looking for.
So it could be kind of a few different things to check out for. And so then a few different follow-up tests may be needed, again, depending on what's going on when you're taking the history and the physical exam. So it sounds like with male infertility, some of it can be genetic in the sense that it's caused by a gene change, but how much of it is inherited or passed through a family?
Yeah. If we kind of zoom out again, for most patients that I meet with, we're often not finding that there's any type of genetic explanation for their infertility. So we're talking anywhere between like 30 to 60% of cases just don't have a good explanation.
And we just don't know what caused it or what's happening. Okay.
Exactly. And then if we look at the cases where there is some type of genetic explanation that's identified, often this is really a sporadic or random occurrence. So something about the chromosomal information has changed during the conception period for that individual that really wasn't something that was inherited from mom or dad. So this is really just a random genetic change that's happened, either that deletion on the Y chromosome or this rearrangement of chromosomal information or potentially having an extra X chromosome. This is typically just completely sporadic. And so we may not see consistent or suspicious family histories like that. With this CFTR related type of condition, though, that's a little bit different. So we often can see that there might be people in the families that are unaffected carriers or have some type of genetic change in the CFTR gene, even if they don't have symptoms themselves. So what we think about for the inheritance for that might look a little bit different.
And that's the one with cystic fibrosis where you might say, like, physically, there might be something going on with the vas deferens that's making us think about this cystic fibrosis CFTR. And then if something's found there, that could have potential meaning for extended family, children, things like that.
Correct. And even from a chromosomal perspective, even if this wasn't something that was inherited from a parent, we now have a patient that has something different about their chromosomes. So this is something that potentially could impact their children down the road when it comes to, potentially having children with too much or too little genetic information. So often we'll have patients consider things like in vitro fertilization. This could be due to the history of infertility or the lower absent sperm count or some other type of factor that's contributing or driving that recommendation to go through IVF. But this potentially could be something that's evaluated, that chromosomal information for fertilized embryos as part of that IVF process.
Okay. And so you mentioned a few different types of, I guess, testing that's available. I mean, how I guess expensive is the testing, or is it covered by insurance? And I know sometimes it's a bit of a mixed bag because, it sometimes depends on the plans. But I was just curious what happens in terms of like diagnosed male infertility, kind of how that's covered in terms of follow-up testing or workup.
So if we have somebody that has a diagnosis of male infertility or, they have lower absent sperm counts, often for many with an asterisk, commercial insurance plans will have medical necessity criteria. And typically those tests, those chromosome evaluations that I mentioned, and that cystic fibrosis testing, often that's included under the medically necessary component of the policy, just because these are standard tests that we use to help evaluate for male infertility. So just because something's covered doesn't mean that it would be free with insurance, but usually it's going to be something that the insurance would be on board with being medically necessary because these are very standard tests that we do. But the out-of-pocket cost may be in some part dependent on the patient's specific insurance when it comes to like deductible or coinsurance and things like that.
And so I guess that's also why to talk with somebody probably earlier in the process to kind of find more information in terms of coverage.
Exactly.
What about questions in terms of life insurance, disability insurance? I know, and I don't want to stereotype or paint with a wide swath, but I will say when I've spoken to my male relatives about testing, this comes up, I think, more often in some of these conversations than other conversations and other people and families that I have it with, is this concern for life insurance.
So as of right now, we still have a federal law in place called GINA, the Genetic Information Non-Discrimination Act. This has very specific stipulations, though. So kind of what you're getting at, in that GINA provides protections when it comes to health insurance, whether that be, a commercial policy or, something like Medicare and Medicaid, because that question comes up a lot for my older patients, and also has specific employment stipulations. So like your employer shouldn't be making hiring, firing decisions about this. They shouldn't really ever know about this information to begin with.
Right.
GINA does not provide protection when it comes to things like life insurance or long-term care or disability. So something that I always want my patients to be thinking about is that if they're interested in getting set up with a new policy in the short term, this could be something that maybe they want to do sooner rather than later before we do the genetic testing, just because there's no specific protections that GINA is offering. So if
Mhm.
somebody has an existing policy, they're kind of locked into that. But if really it's a situation that somebody wants to apply for a new policy, then we can't guarantee that these companies wouldn't ask about this type of information. And if they do, of course, this is something that would need to be disclosed.
Right, right. And I think that that's very important, particularly too if you're talking with families that are or folks that are thinking about starting their families, right?
Hmm.
This is kind of the time when you start thinking about some of these more unfun adult decisions in terms of like insurance and things like that.
Yep. And especially like if we are talking about younger generations or like you mentioned, starting a family, sometimes it's a little bit of a different conversation than when we have a patient that's, maybe already retired and isn't worried about getting a new life insurance or like, long-term care policy. So it's certainly going to be very kind of life stage dependent and what the patient's goals are with testing.
When you have a patient, that tests positive or you find that there's, I guess, a genetic cause for either infertility or in the hereditary cancer area, how do you advise them or what sort of insights do you give them for talking to their families about these test
Mm.
results? Because that can always be a challenge, I think, regardless of, male or female. But I know there have been some studies where it sometimes can show maybe less health communication, I would say,
Mhm.
for those that identify as male.
Yeah, this is something that has been really interesting to kind of see play out in my clinic, just because I tend to see a lot more men or people that are assigned male at birth in my clinic. And so the family communication style, I think, is very different. And one thing, too, though, that I think I see across all of my patients to some extent is that within families, there's going to be different ways that people communicate. And I have some patients that their families just don't discuss medical information or family members that don't disclose cancer diagnoses, or they may not find out this information until somebody's passed away. And so I always really strongly encourage my patients to make sure that they're sharing this information with their family members, just because on a cancer testing side, this can have very significant implications for whether or not we can start cancer screening early for other family members or
Mhm.
potentially prevent or help identify a cancer early. So because of the preventative actionability that often can come with the cancer genetic testing, I strongly encourage patients to discuss this. But there's always going to be, limitations and social dynamics that need to be navigated. But typically in the cancer setting, I'm trying to offer a family letter for my patients so that it can give pretty high level of information about what was identified and how it could impact them and how they can find somebody in genetics. And maybe sometimes this is just a way that the patients can use as a starting off point to discuss this information with other family members. Or, potentially they can just send it and, not need to reach out to certain family members if they're not in, close contact with them. But there's
Mhm.
always going to be family dynamics that are going to be hard to navigate sometimes.
Yeah, yeah, and I'm guessing that's something too that maybe you may chat with the patient about is their own unique family dynamics or in terms of sharing the information and how they think that may go.
Exactly. Because I think sometimes that is a cause for concern for people and that they may not have a lot of communication with one side of the family and it may be a situation that we don't know what side of the family something like this could be inherited from. So then it's trying to navigate, who else do we think is going to be appropriate to do testing? But I think what I hear a lot from my patients is that they do this testing for their kids. So talking about how this is going to impact younger generations and when we need to think about doing testing for them and navigating how the patient may feel about having passed something down to their kids or potentially pass something down.
And what about the expense of genetic testing in terms of cancer testing and the insurance coverage there?
Mhm. Things have evolved very dramatically, I would say, over the last, 20 some years when it comes to the cost of this type of genetic testing. And often it's a lot more affordable than people think it is. But with the coverage for testing, that often is going to be very insurance specific. And often it's going to come down to whether or not a patient meets criteria for testing or there's some type of clinical diagnosis or clinical suspicion to justify the testing. But often the out of pocket cost is going to come down to the specifics of that patient's insurance. So, what does their deductible look like? Co-insurance, copay. And there's some labs that often will offer patient pay prices where we're not going through insurance. So, if we have patients that either don't have insurance or have a really high deductible, this sometimes is a nice option for us to think about for offering testing. And this could be like $250. So it's a lot more accessible than people, I think, have historically thought it's been. But the coverage for the testing is always a little bit specific to the insurance.
One of the things too is that, and there have been several studies showing that people with prostates are less likely to see a genetic counselor, less likely to get genetic testing than their at-risk female relatives. And so I wanted to see why you thought that was.
So I think there's a couple different components to this. I think some of it is going to be on the provider level, where I think just in the breast and ovarian cancer space, the genetic testing for that has kind of evolved as a lot of these providers have been practicing. And so I think it's more standard for them to kind of be thinking about genetic testing as part of their clinical workflow. And so I think if we look at comparatively in the urology space or the GU oncology space, this is relatively newer for a lot of these providers and isn't necessarily something that they've had to navigate. So I think, provider education about them knowing who to actually send for genetics, I think has been difficult. And I think the vast changes that have happened in the testing criteria and the complexity that comes with a lot of the testing criteria, I think has potentially worked against us getting more people into genetics. I think overall, sometimes men are just not as likely to pursue testing if it's not recommended to them by a provider, or they have female relatives that are encouraging them to do the testing. Like, I have patients that come in and they're like, oh, I'm here because my daughter sent me or because my wife sent me. So I think, who in the family is supporting and encouraging the patient to pursue this type of testing, who's coming to them to appointments with them and kind of helping them navigate the medical space. But then I think patient awareness is another thing. Like I mentioned earlier, this might be in the top 5 things that women think about if they have a breast cancer diagnosis. But I don't think the corresponding thing is true if somebody has a prostate cancer diagnosis. So I think culturally, from like a societal perspective, there's differences in how we think about genetic testing and whether or not a cancer would be associated with a genetic cause. And then I have a lot of patients that are like, I've already been diagnosed with prostate cancer. What does it matter that I do this testing? So I think there's potentially some attrition that happens just from people not thinking that it's going to be relevant for them, because like we talked about earlier, they may not kind of understand the scope or context in which their cancer could be impacting other people.
Right. So they may just be like, okay, I'm already getting treatment. I'm already doing what I need to do. What's the point of any further testing?
Exactly.
One thing that I find interesting in reading some of the studies, there's been a few recently, I think, that have come out thinking about, people who've been assigned male at birth and how are we reaching folks who've been diagnosed with prostate cancer or some other cancers like testicular in terms of doing a genetic assessment or offering testing. So these studies have been coming out. I've been looking at them interestingly over the last couple of years, but now that the NIH and other federal agencies, they're no longer able to research populations based on gender. So the administration's stance against DEI and talking about not even discussing gender, right, in some of these studies. How is this going to impact research that is needed to help men access genetic services?
Yeah. And I think this is the big thing with DEI, right, is that this impacts everybody. So well, like I mentioned earlier, we are well behind when it comes to understanding prostate cancer, testicular cancer in the genetic space. And one big thing that we struggle with is not only what genes are more definitively associated with these different types of cancer and understanding what those lifetime risks might be, is also figuring out how we help screen people once they actually have a diagnosis of one of these genetic conditions. And so there's a lot of research that is going into how do we do long-term follow-up studies and how do we follow people from an unaffected or affected perspective to learn more about the outcomes and the cancer risks that might be associated with it, and how do we develop screening protocols for people. So I think there's multiple levels at which this research could be affected, and it's going to be something that's going to slow the field down probably in the long term when it comes to in a field that's already kind of behind to begin with. So I think this is where we struggle, is that how a provider do I accurately convey this information to my patient when it comes to if we find a harmful mutation in one of these genes? What does the cancer profile look like? What do those risks actually look like? And what are we going to do with this information? And if we don't have that research, it makes it a lot harder to have that clinical discussion with patients, because how do we formulate a plan to help care for them?
Yeah, I think it's thinking about various populations that are affected. And like you said, it's not just in terms of like academic research pursuits. It's really the clinical care. How does what we're getting from the academic research translate into benefiting the patient?
Yeah. And I think I would be remiss to not mention, the fact that a lot of the patients that we see in the genetic space, male or female, are white European background. And so, especially in the prostate cancer space, now we're looking at, potentially higher rates of prostate cancer for men that are Black or African American, but we have lower representation when it comes to genetic testing or individuals that are Hispanic. And so we see overall lower testing rates for people with prostate cancer in general, but then we have even lower testing rates for these other populations. And so this is also something that is going to impact that research down the road, because how do we accurately and appropriately support all of our patients if we're not studying those populations and help figuring out how we can better care for them? So kind of an even further level of research that's going to suffer because of this.
Yeah. And thank you for calling that out, because it's the ripple effects. And then, like you said, it puts up barriers to being able to have like the most up-to-date comprehensive information for that patient.
Yeah, absolutely.
I know we've talked about a few different things in a few different areas in terms of like men's health. But what is the one thing that you would want our listeners to take away from the conversation or to remember about men's health and genetics? What do you think is most important?
Yeah, that's a big question to answer. So I think for my patients, what I always want them to take away is that while these inherited conditions, thinking about on the cancer side or the infertility side, it's still important for patients to think about whether or not genetic testing could be relevant for them. Whether that be based on personal or family history of cancer, even if they don't think that cancer could be connected back to their own, there's a possibility that it could be. Or on the infertility side, this could be a situation where there could be some explanation for why somebody hasn't been able to have children. So can we help patients navigate that information and help them figure out what the best family planning options are going to be for them? So I want patients to be thinking about genetics. Because there could be multiple ways that it could be relevant for them. Like I said, it's rare. We're often doing this testing out of an abundance of caution, but I think there's benefit in people having negative genetic testing, especially on the cancer side. So can we provide some reassurance for the patient and for their family? So I think regardless of how those results turn out, this is something that could be helpful.
Yeah, I go back to kind of one of the things that you said earlier, thinking about like just the awareness, whether it's on the provider side, the patient side. It's just having that awareness to bring it up to that provider or to pursue it, or just to say, is this something that's going to help give us some more information, regardless of what the result is?
Absolutely.
Well, Brittany, I just appreciate you being with us today. Like I said, there's a lot here that I feel like we could dive in more in terms of getting into, especially in the urology setting. So maybe we'll have to do it again, but I just really appreciate you being on the episode today.
Yeah, absolutely. Lots of important things to talk about, and I'm glad that we could at least start the conversation.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.